So, hello everyone, and welcome to this digital glaucoma support group on primary open angle glaucoma. And thank you for joining us. Tonight, we're going to be talking about the most common type of glaucoma, primary open angle glaucoma. I'm Liz Ball, Glaucoma UK's Development Manager for Northern England. With me is Robin Asprey, our Development Manager for Southern England, and Robin is going to be keeping an eye on the question and answers and on the chat and doing some of the technical magic to make Zoom work for us tonight. And we're also joined by Sharon Beckett, who if you're joining us on Facebook, Sharon will be feeding your questions from Facebook into Zoom so that our speaker can answer those. And I'm really pleased to welcome our speaker, Rachel Hilton. Rachel is a specialist glaucoma nurse based at the Manchester Royal Eye Hospital. So Rachel, welcome and thank you very much for joining us tonight. Just a few quick words before we get started about how this session will work. We will be launching two polls during the session, one now and one at the end. And these are just so that we can get an idea of how useful you're finding this session. So Robin, could you launch the first poll for us, please? So this just asks you to tell us how much you know already about primary open angle glaucoma. We'll leave that up for a minute or two to give you a chance to answer it. During the session, we do encourage you to ask questions. So if you've got a question that you'd like to ask, if you can type it into the question and answer box, then towards the end of the session, we'll put your questions to Rachel to get her answers. And if somebody else asks a question that you think, oh, I like that, I want to know the answer to that, you can also like the question. If you do that, it'll tell us that it's an important question. So we'll make sure that any questions that have likes get answers. You can also post in the chat box if you've got any general comments or would like to share your experiences, but it's not a question, then pop it into the chat box. So without, Robin, I think, can we take the poll down now? Great, thank you. So without further ado, I'm going to hand over to Rachel to talk about primary open angle glaucoma, what it is, how it's treated, and so on. So Rachel, thank you very much. Over to you.
So I'll just share my screen, hopefully. Let's just check it's going to do that. And from the beginning. So hi everybody, hopefully you can see this okay. So obviously I'm going to talk to you today about primary open angle glaucoma, and as Liz has mentioned, I'm the glaucoma specialist nurse at Manchester Royal Eye Hospital. And just briefly, before I talk to you about that, I just wanted to give you a sense of what I do in my role. So basically a lot of it is this kind of thing, support and education. We do that on a one-to-one basis. We do that on the telephone and face-to-face. We also do group-based sessions, or we did do, and we're hoping to get these back up and running. COVID, unfortunately, reduced those slightly. And we do a lot of other specialised nurse-led services, so things like the eye care home phasing, where we teach patients to check their eye pressure at home, and we see patients clinically on the slit lamp for follow-up. Particularly, we do nurse-led clinics for treatment effectiveness when you've had a change to eye drops or started a laser treatment. And we also help out on the consultant-led clinic, so we will be seeing patients post-operatively, and we have specific things that we'll do for patients, including drop assessments that patients are referred to us for help with administration of their eye drops, and things like CVI support, certificate of visual impairment, sight loss support, We do a lot with the ECLOs, the eye clinic liaison officers, liaise with them a lot. And as you can imagine, in a specialist nurse role, we do a lot of staff education and training and research and service development. So that's just a sense of what I'm doing day to day. I would say that every glaucoma nurse in every hospital may have a slightly different job role in terms of what they do to support the team. But you'll find that any glaucoma or any specialist nurse of any ophthalmic condition, at the very basic part of their job, it will be a lot of care and support and information. So there'll always be a good source of information if you have got one to hand. So we're talking about primary open angle glaucoma, which, as Liz said, is the most common type of glaucoma. So I didn't want to go too much into the anatomy and physiology. You can see here a lovely diagram of the eye, but I did want to just cover what that means, because there are different classifications of glaucoma. And essentially, when we're talking about this, when we say that someone has glaucoma, we're saying that there is some change to the optic nerve. The optic nerve is made up of millions of nerve fibers. And what we're saying when you have glaucoma is that we're seeing some changes to the nerve, some thinning out of the nerve where those fibers are dying off, which then leads to changes in vision. And usually that's in the visual field in terms of sensitivity of vision and areas of vision missed on the peripheral edges on the sides. You can get that encroaching a bit more centrally, and certainly if it's left undetected or untreated or not responsive to treatment, you can get that slight patchiness of vision that just builds up and joins together and encroaches. And this is where you hear the term tunnel vision, because yes, it can develop into that tunnel vision where you have an island of central vision left. So there's always optic nerve damage present in glaucoma. It tends to follow a particular pattern that we can say is glaucomatous. When we talk about the primary aspect of it, we're saying that that is just the way the eye is. And what I mean by that is that there's no secondary cause, because you can get some glaucomas that are caused by other eye conditions or systemic conditions. So, for example, uveitis is a big one. When you have inflammation within the eye, unfortunately, that causes issues that can give rise to intraocular pressure going up and then changes to the nerve. So you can get these secondary glaucomas from all kinds of other conditions, but in this case, it's primary. It's simply the way the eye is. And the bit about open angle is important to note. So I've mentioned we concentrate a lot on the nerve. That's where the damage occurs in glaucoma. But the other part of the eye we concentrate on is that front portion that you can see in the diagram, where you have the cornea, the very first front layer, the iris, the colour part of the eye, that's the muscle of the eye after that, with a hole in the middle, which is a pupil, and behind that, the lens, which you can see that oval shape there. And the fluid that circulates within that is called aqueous humor, and that's responsible for regulating the eye pressure. It also provides nutrients and takes away waste products to those clear structures in that section of the eye. And what should happen is it's produced by the ciliary body, you can see labelled there. It flows in front of the lens through the pupil, circulates in that front portion behind the cornea, and then it drains away. And it should be produced and drained at a similar rate. Where it drains is what we refer to as the drainage angle. So when we talk about open angle, what we mean is that the fluid can actually access that area to drain away. So just to cover that very briefly, so we're not labouring too much about the anatomy and physiology, but so hopefully this makes sense, where you have your cornea and your iris, one behind the other, with a gap obviously in between, as the diagram shows, where those two structures meet at the peripheral edge. So at their edges, they meet slightly, there is a gap between there. That is where the drainage system sits within the eye that the fluid has to pass through. And we're talking a really, really small area. And there are various structures within there that you might have heard of, things like trabecular meshwork, Schlem's canal, but they all sit within that area, and the aqueous passes through and is eventually absorbed into the rest of your body through your episcleral veins. We're talking as well, that's 360 degrees all the way around, just to make it clear, because sometimes on a flat diagram, it's a bit hard to sort of picture. So if there are issues with that area, the cornea and the iris at the edge being very, very narrow, and unfortunately in some cases that can even close off, and that is an ocular emergency, that is slightly different, and it can give rise to glaucoma, but that's different to what we're talking about. In this case, that angle is open. The fluid can access that area, but unfortunately it's not passing through the drainage system within there as easily. So with any of the glaucomas that we talk about, they are a chronic condition. Once nerve damage occurs, unfortunately we can't get that back. So it's the key with this particular type of glaucoma, and arguably all types of glaucoma, that we want it to be detected early, and we want to get people into treatment that is working for them. When we're treating glaucoma, we are focusing a lot on eye pressure. And that's because it's the one modifiable risk factor. So we know that having high pressure within the eye means you're more likely to develop optic nerve damage, and you're more likely to develop glaucoma damage. So with any of the patients that we see with primary open angle glaucoma, they may very well have high eye pressure outside a normal range. A normal range is 10 to 21 millimeters of mercury if we're talking textbook range. So they may have a high eye pressure. And then we certainly know we need to get it down, because that's the one thing we can treat, and then we can protect the nerve. However, we do have some patients that will come to us with a quote unquote normal pressure, where actually the pressure is within that normal range, but we're still seeing change to the nerve. So for those patients, we're still aiming to get the pressure lower so that their eye can cope with pressure of a lower level that isn't going to damage the nerve. So with primary open angle glaucoma, it's important to note you can have high pressure, but you can also have low or normal pressure and still have this condition, and still we work on treating the pressure, because we know that is the thing we need to change to protect the eye. So this slide up briefly, just to kind of give you a sense of what patients have said they wanted to know, and hopefully the kinds of things I've tried to cover. But I'm well aware I've jam-packed this presentation, so I'm not going to talk about this in great detail, but these are some of the things that patients have sort of flagged to us in the early stages that they'd like more information on. Obviously they want to know what the condition is, what treatments are, how to navigate healthcare system, you know, where to go for the information, etc. So these are the types of things that I'm going to try and cover in this presentation. I do want to talk about management of glaucoma, because I think that actually, although I'm going to briefly go over some treatments just so you get an overview, what I often find patients reporting back is that there isn't quite as much time when you're seeing patients, when you're seeing your clinicians in the clinics and discussing treatment options and prognosis and so on, that there's not that much time to go through everything, and perhaps there's not as much understanding as to why that is being offered as a treatment, why certain decisions are being made. So really just to cover what is going through your clinical team's minds and what they really should be looking at when they're offering up certain treatments and discussing it with you. The aims of the treatment always for us is obviously to avoid significant loss of vision in a patient's lifetime. We want to make sure we're preserving your vision for as long as possible. We want you to have a good quality of life, and it should be tailor-based to your circumstances. We want to lower the eye pressure. That's the one modifiable risk factor we concentrate on, and we're usually aiming 25 to 30% lowering based on what evidence tells us, but essentially that's going to be based on where you start with us and where the damage has occurred. So everyone's target eye pressure may be slightly different, but we're aiming to get that lower to a point where you don't get damage, or we slow down the damage. And we also want to concentrate on starting something but reassessing, and if that doesn't work, going to the next option. So that's the kind of aims that we look at. Treatment options are always based on a variety of factors. We want to be considering life expectancy, or the healthcare or the health conditions you may have that might affect the type of treatment we offer. How severe the damage is. Obviously, if you're coming to us already with some glaucoma damage, maybe it's been undetected or unresponsive to treatment elsewhere, for example, we might be suggesting something that is sort of a little more intensive, a little more invasive, things like surgery, a little earlier than patients who have very, very minimal damage. We're also looking at other risk factors. So are there reasons why your glaucoma might progress more quickly than other patients? We're looking at contraindications for treatment. So one example I can think of recently is a pregnant patient that we saw who didn't feel comfortable taking the eye drops, and there are some contraindications to some eye drops at certain stages of pregnancy, and so we opted for laser treatment. We obviously want to go for something that we know is going to work. So efficacy of treatment is based upon evidence that we have from lots of years of research into what works best for what patients with what type of glaucoma. And obviously we want to make sure that patients can tolerate it. So if you're struggling with eye drops, you're not managing, let's say you have lots of allergies to drops, lots of side effects with them, we're more likely to then suggest a laser or a glaucoma treatment, a surgical treatment for glaucoma, rather than persisting with drops that you're just not going to tolerate. So lots and lots of factors we take into consideration. And if you do want to have a look at this in a bit more detail, I would certainly recommend looking at NICE guidance. It may be a little sort of clinician focused in terms of how it's written, but the idea is it's for patients to look at as well, because what NICE guidance tells us is it gives us a pathway of treatment options and what we should offer at what points. And it's been put together by healthcare professionals on a board, to recommend based on evidence available what we should do for our patients. And you'll find all of your glaucoma clinical teams will follow that NICE guidance, and they do deviate from it from time to time, but generally speaking, it will follow that pattern. So there's lots of medications that are available, and this is a very busy slide, apologies, but I just wanted to make sure they were all mentioned, all the different drug groups, because these are the main drug groups. Most of you may have heard of prostaglandin analogues, latanoprost, travoprost, because that usually is first line treatment in terms of drops. And after that, we have beta blockers, tends to be the second ones we offer, alpha agonists, carbonic anhydrase inhibitors, and the miotics. They'll all work in slightly different ways to help with glaucoma. So essentially what they're doing is either reducing the eye pressure by opening up the drainage system a little bit more, or reducing the eye pressure by reducing the amount of aqueous, that fluid that circulates in the front portion, that's produced. So if we have less of that, we have a lowering of the pressure, or if we have a better outflow, we get a lowering of the eye pressure. And some people may be on a combination of these drops. Certainly, there are even combination drops available. For example, the sort of most common one we see for us is Cosopt, which is dorzolamide and timolol. So you will see various drops available, and we go for what works for you. Whenever we start a drop, we need to see if it is actually working for the eye pressure, and you may be on a combination of drops. I've listed a few side effects there. Please don't let that worry you. It's just those are common ones that we may see. Not everyone will get side effects, but it's important to note that if you are getting any side effects, that you do tell the clinical team, because there will be other options. As you can see, there's plenty of drops available. Next set of treatments that we can offer would be laser. Now, I would say historically, the laser would be the next step, as I've just said, really, in place of drops or on top of drops. There is a lot more evidence in recent times to suggest that we should be offering laser as first-line treatment, certainly the selective laser trabeculoplasty. So the difference between these two lasers that I've mentioned here, the selective laser trabeculoplasty works on the trabecular meshwork, which is an area of the drainage system, and it actually stimulates the cells in there to improve the outflow of that fluid. We find it works really well in about 70% of patients, and it can last a good number of years. And once it starts to sort of fade and the cells aren't working as quickly, we can repeat it. We tend to only repeat it a couple of times, but it is an option. The cyclodiode micropulse laser we offer for patients maybe a little later down the line, only because we can have the problem of it affecting the vision slightly after having it. And what that does is it works on the ciliary body that produces the aqueous to stop it from producing as much. So again, we get a lowering of the pressure. I've mentioned about recent evidence, and the LIGHT trial, which you can see there, it has shown us that SLT actually works really, really well as a first-line treatment. And NICE guidance has actually been altered to reflect this. And the reason is we find that, the benefits of SLT, as you can see there, are that a lot of patients, sort of 3/4 of them in that research, in that trial that's been done, were drop-free at 3 years. So there's less reliance upon drops. We've also found that evidence is telling us that the disease progression is slightly reduced, and that the fluctuations in eye pressure were better controlled, and that the eye pressure was, stayed at a good target at follow-up visits. And obviously with SLT, if we get patients off drops, then we don't have that reliance upon them and reliance upon getting the drops in regularly, and less in the way of side effects. The sort of caveat for this that I would mention is this research, although it is looking really positive, and this is why NICE guidance has been changed, it's been done around new patients who are more newly diagnosed, perhaps are less progressive in their condition. So there's some argument to be said when we're talking about first-line treatment, we are talking about, earlier stage. You can have SLT later on, but we're talking about this in relation to patients who maybe haven't had other interventions. The other thing to mention is, whilst this is great, and I think more and more people will be referred for this, perhaps over drops, in your units, it will depend on who can do the laser and how many laser machines you have. So if we see more and more laser being used and it's really effective, we might be able to increase the number of people that are performing the laser. But I would say at present, if you're not being offered its first line treatment, it's probably related to how many people can do the laser, how many machines are available. And often what I'm finding in the hospital I work in is we're starting people off on drops until the laser appointment can be completed. So it's sort of a first line treatment, but I think it's kind of needing some time to get there. And surgeries, I won't go into all the details of these surgeries, but just to mention a few of the kind of key ones that may have heard of: trabeculectomy, tube surgery, and minimally invasive surgeries. They're sort of three main groups, if you like, that I would kind of refer to them as. Trabeculectomy is our gold standard surgery we've been doing for a very long time. What we'll do with all of the surgeries is we're aiming to reduce the pressure by creating a bypass of the drainage blockage, if you like, a bypass of the drainage system, and creating a permanent outflow for the aqueous. With the trabeculectomy, we do that surgically by making a little hole there and suturing an area down to titrate the amount of fluid that's escaping the eye. So that runs from the anterior chamber where the fluid circulates just to underneath the eyelid in the subconjunctival area, so that white of the eye will have a little raised area under the eyelid where you get the fluid pooling before it's absorbed into the rest of the body again. The tube and the minimally invasive surgeries can work similarly. With the tube surgery, we actually have a tube passing through that drainage area and bypassing it. Again, that slight pooling and that outflow is created. And with some of the minimally invasive surgeries, we have a similar thing happening. So with the PreserFlows, for example, or microshunts, sometimes they're referred to, we have a tiny little stent that's within that same area. It's just a lot smaller in size. Some of the other minimally invasive surgeries, we're actually placing stents within the drainage system, so there's no outflow. And there's lots and lots of options for us with these minimally invasive surgeries. There's new things happening all of the time. What I would say are the key differences is obviously the less invasive the surgery is, in theory, there's less complication, less follow-up, but we may find that we don't get the eye pressure as low. With the trabeculectomy and the tubes, for example, we get a really good reduction in eye pressure, but they're more prone to, having the need for more follow-up and the potential for complications. So again, when it comes to looking at options, you'll be offered different things depending on your circumstances and how low we need the pressure to go and what we think is going to be successful in your case. But all of these treatment options are there for primary open-angle glaucoma at various stages. I did want to focus sort of looking at the medications, because as I mentioned, medication adherence is a big one for us, and it's a huge part of our job really as glaucoma nurses, because we do find that evidence tells us 1/3 to 1/2 of patients who take medications for chronic conditions like glaucoma don't take them as recommended. And I would say for patients that I see, the main problems we tend to find are either problems with physically getting the drops in, or other problems relating to the drop regime or accessibility of drops and so on. So I've listed a few here. So the physicality of putting the drops in tends to be issues with squeezing, with getting it in the right position, with head tremors, hand tremors, with not being sure about how to actually instill them and avoid, getting the nozzle of the dropper into the eye. And so there's lots of sort of physical aspects to it where we can teach patients to use different method of putting the drops in. The different techniques, as you can see, there's an example there of having the bottle over the bridge of the nose to help with positioning. But I would also say there's lots and lots of support out there in terms of videos online, leaflets and so on, lots of guidance besides your glaucoma specialist nurses or your clinicians that you're seeing in clinic. And even if that doesn't seem to be available, or you feel happy to try a drop aid, I would go for a drop aid, because there are lots of drop aids for different types of drops, different styles of drops, bottles and individual minims. And what those drop aids will do is provide you with a holder to have the little individual unit dose or the bottle in that can go onto the face, so it helps with positioning, and it also helps to avoid poking yourself in the eye, and a lot of them do help with squeeze as well. So there's plenty of options for resolving these issues, but do tell somebody if you're struggling. The other problems that we see, such as fitting into routine, remembering to instill, again, there's things like alarm setting, drops charts, putting it in a visible place, tying it into the usual routine that we would suggest. But ultimately, if you're really struggling with any of these things, I would encourage to speak to your clinical team and see what they can do in terms of reorganizing that routine. It may be that they can change the drops that have been prescribed. It may be they can look at combination drops, etc. When it comes to side effects, again, I would definitely encourage, please have that discussion rather than stop using anything. I do often find people are ringing with issues with getting hold of them from the GP or pharmacy. And again, if you have one of your clinical team that's able to contact the GP to discuss these issues, please do utilise that. I often will ask GPs to prescribe, for example, 2 bottles at a time every month for patients who are struggling to get them in. So there's ways that we can work around it. And again, if you're not sure why you've been prescribed drops at all, you've got uncertainties about it, please speak with the clinical team. But it's really, really important for us to know if somebody isn't taking the drops, because we know then you're not being treated as we think you are, and the pressure is probably not being controlled. So the other thing I wanted to cover, besides those kind of drop problems, are the main questions that people come to me with about glaucoma in general, but particularly primary open angle glaucoma, with it being, you know, the most common one. So a lot of people ask about certain lifestyle factors and what to and what not to do. When it comes to exercise, there is some evidence that you may have heard about to indicate that some light aerobic exercise can help to control intraocular pressure. And so I would say I'd encourage anybody anyway, just for health reasons, to try and have a little bit of exercise on a regular basis. No need to go overboard, but there is some evidence behind this as well to say that it helps to control intraocular pressure. So there is some truth in that. When it comes to certain activities, though, people do get cautious, things like yoga, weightlifting. The reason we say to be cautious with that, and that you're quite right to be cautious with it, is because with yoga you're doing inversions. Anything where you're bending the head down can elevate the intraocular pressure temporarily. Same with weightlifting, where you're lifting, straining, that can elevate intraocular pressure. I would please encourage you not to just stop doing physical activities like this. If you would, just speak to your clinical team. It doesn't mean that you'd have to cease these things and never do them again. It just might be something to make them aware of and be cautious with. In terms of smoking, there isn't a direct link with glaucoma, but a bit like the exercise, definitely I would encourage anyone to try and cut down or quit if you can. And that's more to do with the fact that nicotine is an optic nerve toxin, and we want to keep the optic nerve as healthy as possible, especially in glaucoma. And also there are other factors where smoking can affect your eyes in different ways. So it can, give rise to dry eye, encourage cataract formation. It can cause issues with macular degeneration. And so there are other links to other eye conditions, even though with glaucoma there's no direct link. When it comes to diet, people do ask about this. I have to say that the caffeine thing, I'm a coffee drinker. I wouldn't say don't drink coffee, but it's just within moderation. So 5 cups or less, usually okay. Small amounts of fluids throughout the day. Some people hear about if you have a lot of fluid intake, it can increase your intraocular pressure. Yes, if you had a lot in one go and then we measured it straight away, it may elevate it, but you're okay to sort of drink as normal. Again, even small amounts of alcohol, fine. When it comes to diet, people do hear about things like the B vitamins and folate, and we do look at that because those are neuroprotective nutrients, and we want to make sure that you have enough present within you. So obviously having a good balanced healthy diet does help with that, but if your clinical team were ever concerned that you may be deficient in those, they will do blood tests for it. Omega-3 fatty acids, those things that are in freshwater fish, there is some evidence to show that they improve ocular blood flow, and you will hear about supplements such as ginkgo biloba, which does also improve ocular blood flow, and it does work for that. It is a blood thinner at the same time. So we'd always encourage you, if you've read about something and you want to take it as a supplement, and there are links to show that obviously that can help optic blood flow, to be cautious and speak to your clinical team. So for example, with the ginkgo biloba, would say, you are at increased risk of hemorrhage with a blood thinner, and if you're already on other blood thinners and you take this on top, it may be a risk to you. So it's things like that where we'd say, if you've read anything, you want to trial anything like this, please do ask, and at least your clinical team's aware. Marijuana I've mentioned because there's a lot of talk of that in more recent times. It does actually decrease the intraocular pressure, but it's not a permanent thing, and it may last 2-3 hours or so. However, unfortunately, unless you're going to be consuming a lot of that, it won't control your intraocular pressure sufficiently, and you can get other side effects with it. Drugs, it's again worth bearing in mind when you do take drugs for other reasons, other conditions that you may have. We would not want you to stop taking those through fear of it increasing your intraocular pressure or affecting your glaucoma in any way. There's certainly plenty of things that people do need to take on a regular basis that they absolutely need for other conditions. Steroids is a big one. A lot of people take steroids, whether that's inhalers or steroid creams. We would like to know about it because it may very well affect your glaucoma. As you can see here, it's either going to be related to ocular blood flow, neurotoxins, or raised intraocular pressure usually, but please do tell your clinical team. And it's just a case of, again, bearing this in mind, and where we can avoid steroid use, we will do, but if you need certain things, you will need to take them for the conditions. And, you know, they're equally as important as your eyes, so we would have to potentially liaise with whoever's looking after you for other conditions and see what we can do to titrate medications appropriately. Glare and sensitivity, a lot of people complain about this. I would say speak to your optometrist, because it's really important to get a good tint on your spectacles if needed, because for some people just a simple bit of a tint or an anti-glare does help. Other concerns that people come up with tend to be to do with things that they want to do in their life, and certainly flying, there's no issues with that, no problems with traveling. Wearing contact lenses, again, no problem, but just be aware that they can be affected by your eye drops. So we'd always say leave a good 15-minute gap before you're putting the contact lenses in. And obviously for some surgeries, it might mean that you can't wear them post-operatively. Playing musical instruments, it's a bit like the weightlifting, holding your breath. So anything where you're going to be holding your breath for periods of time can elevate the pressure. Again, it's not to say that you have to stop doing that. Similarly with the clothing, we wouldn't be saying never wear a necktie, but it's just bearing these things in mind. And sometimes people hear about this, and there is definitely some truth in it, that it does elevate your pressure, but they're just things to be wary of. And if you do play a wind instrument really frequently, again, discuss it with your team, just let them know. DVLA, I would certainly say, just for clarification, a lot of patients ask about this. There are certain driving standards, and essentially what they want you to do is to be able to see a number plate at 20 meters away with corrected vision, and also not have a visual defect that is going to affect you when you're driving. So the tests they do for DVLA are with both eyes open, it's with corrected vision, because they want it to be as you would be if you were driving. And we have plenty of patients that drive with just one eye. Essentially, they can have no vision in the other eye and still drive. However, the key is, have you got a full field of vision that means you're going to be safe enough to drive? So the DVLA will do that testing. Your clinical team will be able to tell you if they had any concerns, of course, but it is ultimately the DVLA that tell you whether you can or can't drive, and you can certainly appeal and have retests. However, please bear in mind, if they're telling you that they don't feel it's safe for you to drive, it is because it is not potentially safe for you or other people. However, if you can see across the horizontal, you have that full field of vision, they will take into account that you might miss the odd one or two little spots when they're testing it with the lights flashing up. So it's not a case of if you miss something, they're automatically going to tell you can't drive. I have put on here that it's about clusters of patches of vision loss that they're going to be concerned with, or anything that's sort of in that central area that they'd be worried about. So just moving away from those lifestyle factors, I wanted to again talk about a few things that I think people often come to me with questions about. And some of it is who is actually going to see you in the service and how the service operates. I can tell you more about my service. Every hospital will be slightly different, but I would bear in mind glaucoma teams are usually quite large. Because the services are quite large, it accounts for a huge number of outpatient services. And what you'll find is the people who are involved in your glaucoma care is expanding all the time, and that's because it's an ever-growing population. People are living longer, people are being diagnosed earlier, and it's a chronic condition. We don't discharge people, so you might have all manner of people involved in your care, and they might actually be seeing you on the slit lamp clinically, and it doesn't mean that they're not qualified to do that. Anybody who is more junior, anybody who's not a consultant, whether that's an ophthalmologist of some kind, whether it's a nurse like me or an optometrist, an orthoptist, etc. They will always working under a consultant, and we will certainly be running things by your consultant team. But a lot of people are doing advanced roles now, so please don't be worried if you are seeing somebody who is, say, for example, an optometrist, and they're doing a laser treatment for you, or they're removing sutures post-operatively. They will have been trained to do that, and we have optometrists doing that in our eye hospital who are very, very advanced, and arguably more advanced than some of the trainee ophthalmologists coming through, because they've been doing it a lot longer. And again, this is just to give you a sense of how the systems usually work in glaucoma. We do tend to operate on a risk stratified system. And what I mean by that is you might be seen in various clinics, and this will be the same in a lot of hospitals actually, although I'm basing this on how we work in Manchester. We tend to do it based on your risk factors. So if you are very low risk, we might need to only see you in our evaluation clinics where we do all the tests, and we see whether or not your glaucoma is progressing based on your visual fields, based on your eye pressure, based on the images of the nerve, and then we can review that routinely. And that works quite nicely where you don't necessarily need to see somebody on the slit lamp face to face to have a chat there, and then we'll just do the tests and write to you. We also tend to have optometry-led clinics in Manchester. Our optometrists see all of our new patients and a lot of our medium risk patients. And then we have our consultant-led clinics for those patients who are a little more complex. Certainly all the surgical patients will be seen on a consultant-led clinic. And it may mean that we have other people working with the consultant. For example, I see patients on a consultant-led clinic, but the consultant's always present on those. And so, there's always a big team working with them, but the consultant is there for that overall, decision-making and overview. And then we have other clinics coming up. So I've mentioned the nurse-led clinics that we do for treatment effectiveness, and, specifically designed for a little bit of nurse input, particularly when it comes to medication adherence or advice post-laser. We have community-based clinics now where some of the community optometrists who are specially trained in glaucoma are seeing our very low-risk patients. And again, you'll see that there are other services available that you may refer to. Things like online services, online consultations might be happening in some hospitals. We'll have laser clinics, face-to-face appointments for support and education, or online support and education, orthoptist reviews, contact lens appointments. So there's lots of people involved in the team, and you may be referred to other clinics for specific things like that. And in terms of support, there's loads of support available. So I'm conscious of time. I don't want to kind of go into too much detail about this, but if anyone has any specific questions, I would certainly say that in terms of practical support, if you're really struggling with vision, we tend to look at the ECLO services that are available, and if appropriate, then registering for certificate of visual impairment as sight impaired or severely sight impaired, because that does help to access services. But if you have ECLOs available to you, they're really, really good. Again, things like Glaucoma UK and any of the other ophthalmic charities are really good sources of information and support. That includes social support, and whilst we try and do what we can in hospital environments, often we find that people like Glaucoma UK are doing a lot more in terms of that peer support and interaction, because they're able to put on things like this where people can interact and at least meet other people, and they have the great surgical buddy service and things like that available. Technology and practical aids, there will be things like digital tech services that you can be referred to, or have a chat with the teams about what's available in terms of low vision and technology there. Emotional support, there's a wealth available. I would certainly encourage you to find someone in your clinical team that you do feel comfortable to chat to about anything. This is sometimes where glaucoma nurses help out, because that's part of our role, and we sometimes have a little more time to kind of discuss things. But there's lots of specific support available, even formal counselling, with counsellors that understand about ophthalmic conditions as well, and lots of financial help and help supporting people who are in work or in education as well. So lots of things out there, but please do ask if you're not sure what's available and what is accessible to you, because often things are missed when you've seen your clinical team, and it's about what treatments we're offering you, and getting the pressure lower and monitoring the nerve. And sometimes I find these things are missed in terms of conversation during your clinical appointments. So please do ask somebody if you're concerned about anything and you need support. And then just very briefly, so I've tried to whiz through all of this, so I wasn't taking too much of your time. For the future, again, it's another thing that people ask me a lot. And I have to say, if we're not currently doing something in various hospital services, it's because, the evidence isn't there for it yet, and it's still a work in progress. There are definitely things happening with drug delivery. And, examples of this may be the idea of having a pellet within the anterior chamber that just slowly delivers the eye drop that you would normally be instilling yourself. There are improvements in surgical intervention. I've mentioned that lots of minimally invasive surgeries, and those are being developed all of the time. In terms of other things like the ROC inhibitors, different glaucoma medications that are neuroprotective, etc. There's new things happening with those all of the time, but if something again isn't routinely available, it is because there isn't as much evidence out there yet, and it hasn't been taken up as such as a regularly prescribed thing. But these are all things that will come up in the near future. I also suspect that technological developments will mean that you're able to do a lot more at home in terms of visual field testing, perhaps, and even taking an image of the nerve at home. We already have the phasing that we can offer where you can check your own eye pressure at home when we loan the devices. And I think there's going to be more and more movement towards that, so that it helps with monitoring. And also it means less visits into the hospital. And one thing I really wanted to mention is this idea of advanced roles, because I know often it does make people a bit twitchy if they're not seeing the consultant, but there's a lot going on in terms of optometrist and nurse and orthoptist involvement in glaucoma care, and training those allied health professionals up to deliver a really good high level of care. And anybody who is seeing you for various things, as I say, it might mean they're seeing you post-operatively or they're doing a laser treatment, they will have been trained specifically to do that task. And I think you're going to see more of that, and maybe more community optometrist involvement, just because services are growing and growing. So I do feel that was a real whistle-stop tour, so apologies if it seemed very speedy. I'm happy to go over anything, but I didn't want to take too much of your time, and hopefully that just gives you a kind of overview of what primary open-angle glaucoma is, but also how services work, how it's treated, and if there are any questions, then we'll go through things again, and hopefully I can answer them for you. So thank you for listening.
Great, thank you very much, Rachel. That was a really useful overview for people. I think really clear and helpful. So great. So anyone who's got any questions, please do pop them into the question box. We've had a few questions come in already, which is great. You mentioned phasing and home monitoring, and one of the questions that's come in is about that, and the question was about whether you loan the equipment out to people to do that, and if so, sort of which kinds of patients are likely to be offered that.
So as I say, every hospital will be slightly different, but they'll probably follow a similar pattern. Not everyone has this service up and running, but we loan the eye care devices. So those devices mean that we can get patients to check their eye pressure at home. Usually we say every couple of hours during waking hours. And the type of patients we do that for tends to be earlier stage patients where we're trying to determine if it's normal tension or low pressure glaucoma. So if we see a patient in clinic, it's a snapshot of that eye pressure at that moment. It may be that we're getting fluctuations outside of the hours that we see patients. Some people are particularly high pressures, maybe first thing in the morning before they get to us, or of an evening, not during our clinical hours. And it will give us a sense of what those fluctuations are and whether they truly fall into that normal tension category. Excuse me, I can feel a tickle. I'm going to have a little sip. Apart from that, it may be patients who just are having, excuse me, progression in their glaucoma. And we're trying to see, again, is it well controlled enough on treatment that they're on? We have had it in other circumstances, and it tends to be patients who have particular conditions, maybe such as pigment dispersion, where we get the dispersion of the pigment within the anterior chamber. We find that we've had patients who, sorry, I've got a real tickle, apologies, that have undertake exercise, for example. As they're doing their exercise, they get a release of that pigment. And so we're actually monitoring specific things they may do. Again, I've had a lady who does yoga as teaching. We wanted to see if that was affecting the eye pressure. So there are other specific conditions that we might say, okay, let's loan it to yourself. We're not sure what's going on. But I'd say the two main ones are, is it truly normal tension glaucoma, and why is there this progression there if we think things are well controlled and we're just seeing what are we missing outside of that.
Great, thank you. We've got another question asking about the role of nurses in laser procedures. Can nurses be the ones to actually do laser procedures?
So they may be. I would say at the moment we don't do it. I personally don't do this at the eye hospital yet. I think my colleague may in the future. I know that's a particular interest of hers. I'm personally more interested in the post-operative care. So I think it's likely to happen in the future. Anybody who's doing laser treatments, so the professionals that we have at our hospital that do laser, we have, for glaucoma, we only have the ophthalmologists, who obviously are already trained. As part of their training, they will be trained in providing the laser services that we do for glaucoma. And we have an optometrist that also does this. You have to undergo a significant amount of training, obviously. A lot of us working in glaucoma have extra specialist sort of academic qualifications and some clinical qualifications, but it requires you to have significant training on, providing that laser treatment under consultants. So we have one optometrist doing that. We do have an advanced nurse practitioner who performs a different type of laser, not a glaucoma laser. And again, she's not only an advanced nurse practitioner, so she's undertaken a lot of specialist qualifications in terms of ophthalmology. She's also had to be trained by the consultant. So any nurses doing what may have once been sort of an ophthalmologist's remit will have had significant training under a consultant to get to the point where they're able to independently perform whatever that procedure is. So for us in glaucoma lasers, we don't currently have any nurses doing it. There may be units elsewhere where they do, because I know one of our advanced nurse practitioners does a type of laser, but it is likely to happen in the future. But again, please be reassured, it would be the same level of training that anyone would have for undertaking any clinical activity. And it is extensive and significant and always under a consultant.
Great, thank you. You touched on the question about yoga and doing things that involve inverted head being lower than the heart. And we've had a question here about that. Someone saying that he does this and his doctor says it's fine.
Yeah.
Should he be confident about, how confident should he be about doing that if his doctor says it's okay?
I mean, honestly, I would say from my experience, whilst we say be cautious about it, let us know, I found that it hasn't actually affected a lot of our patients who've told us they practice this regularly. In terms of, I can think of a couple of patients, one in particular who was very concerned because she's a yoga teacher, and as I mentioned, she did the phasing, and actually when we were measuring it sort of immediately after, it's very difficult to get a pressure reading, of course, in that moment where you are inverted, but we were doing it as close as possible to just after, and there were no fluctuations for her. So whilst we know it can encourage your intraocular pressure to go up briefly, for the most part, I don't think, I don't know of any clinicians that would say absolutely stop it. I think it's just important to let them know. If ever they were worried at all, you may be able to do the same sort of thing that we've done for our patients, where we would give an eye care device to monitor at home, or we may even, test that out clinically, if that's not available, and do the traditional Goldman applanation tonometry. But I would say, as long as your team know and they're aware and they're happy for you to do it, it shouldn't be a problem, but it's just something we're cautious of. And it does really depend on how often that's happening, of course. And, it will be temporary, but it's important to just let them know that you are practicing that and maybe how often.
Great, thank you. Really, really helpful and hopefully reassuring to people as well.
Yeah.
Thank you. We've got a question, well, actually a couple of questions about what happens when treatment isn't adequate. One person saying has been on latanoprost for a long time and been offered SLT, but the consultant said that can only be repeated a couple of times. What happens then? And someone else asking what happens if treatment just keeps not working, nothing's really getting the pressures down as low as they need to be.
Yeah, so I think it really depends on, when we talk about the pressure, we're talking about on the one hand what the number is and, you know, how low it needs to be for that individual, and then we're talking about the damage to the nerve. So all of these decisions are going to be based on, if treatment isn't working, normally what we mean by that is that the pressure isn't quite low enough to keep that nerve protected, so then we opt for something else. So I think in terms of that number, it depends how low they want it to go as to whether they'll think, right, we're at a point now where we'd say that treatment isn't sufficient enough, let's move on to the next thing. Because, you know, the pressure might be sort of not super optimal, but we're still happy to watch and wait. But if it's getting to a point where it's too risky for the nerve, we'll offer something else normally. So yes, you can get to a stage where treatment has been working great for you before. Classic is that, you know, drops that have been working great just becomes less effective over time. And, you know, we do see that. And obviously we can then try another drop or add a drop in, but we will get to a point where you have a maximum number of drops before we'd say, look, you've got the most now and we're going to need to opt for something else. And then we have got the lasers available. Particularly the patients that we get at Manchester and the ones that I tend to see a lot of, probably because by their very nature they need a bit more input. We have a lot of complex cases there where glaucoma isn't well controlled, you know, the pressures aren't well controlled, we're still getting changed optic nerves. So, you know, we do see a lot of patients, or I'm aware of a lot of patients that will have multiple surgeries. So usually we're not at a point where we've absolutely exhausted everything. It's just that it's not ideal for you as the patient if we have to keep going in and intervening, but there are plenty of choices and options. So it's difficult without knowing where you're up to individually, but I would certainly say we have patients at the eye hospital that have had multiple surgeries, you know, multiple tubes, even a trabeculectomy and then a tube and another tube. You know, whilst there's space in the eye, if we can intervene, we certainly will. But it may be that we opt for something that's going to be a little better overall for you if we're really struggling to control it. Things like that cyclodiode laser that I mentioned, where we just stop that part of the body producing as much aqueous. You know, so we'll often go for certain things a bit more later down the line, but there are lots and lots of options. And they're even getting to the point, for example, where we've had issues with tubes or trabeculectomies not working as well, and then we're actually using some of the minimally invasive surgeries to open up those a little better and you know, inserting little stents within existing surgical areas. So there's lots and lots teams can do. It's just, as I say, a shame if you're at that point where you're needing lots of intervention, but we'll never give up on an eye, and we will keep going if we can to make sure the pressure comes down. And what you might find is that we surgically intervene, or we do something, and then we say, look, we need the drops on top just to give it a little bit of an extra boost to bring the pressure down. So you might be on a combination of treatments, and in an ideal world we'd have things done and dusted, less drops going in, less invasive treatments, but where we have to intervene, you know, they should keep going. And if they're not sure in terms of your hospital and where you are, they'll refer you to somebody like us or like Moorfield, for example, that kind of deal with complex cases. And, you know, that again, that's always another option to get another opinion from somebody sort of super specialized.
Great, thank you. Again, really reassuring for people to know that there are so many options. An interesting question here about the link between glaucoma and the immune system, and specifically whether immunosuppressants and autoimmune diseases might have a link with glaucoma.
Well, I think in terms of what we see, it tends to be that we see issues more with we can see with immunosuppressants being used that we have issues with the drugs themselves affecting the intraocular pressure, and therefore there is a link there. I mean, for some people, having a particular condition can give rise to other things in the eye that then cause the glaucoma. For example, then you get a uveitic response, you get inflammation within the eye. So there is certainly a little bit of a link there. I would say it's more likely to be to do with the drugs that are used to treat certain conditions that then cause issues with glaucoma and pressure in the eye.
Right. And another question about plasma medications and links with glaucoma, around, I'm not sure if I'm pronouncing this right, apologies if I'm not, glucosamine, does that have a link to glaucoma?
I mean, I'm not sure off the top of my head, but it depends. So glucosamine.
Glucosamine.
Ah, yeah. Yeah. So I think, yeah, I'm not aware of this particularly, because I think, in terms of this, because I think is it arthritic medication, but I'm not aware of it particularly having an affecting this type of glaucoma. I mean, it's something I'd have to look up, because there are certain drugs that they'll say for other types of glaucoma, like the narrow angle, it can have an effect, but it's not something I'm aware of with this one for primary open angle. I can look into it and get back to you for sure, but it's not something I've heard of personally. So yeah, I don't think so with that one.
Okay. And a couple of questions about getting access to treatment and support. If you've had an appointment but no one's really sort of talked to you about the support that's available, how you access clinical teams, and if you think that you need different treatment, do you speak to your GP? Do you speak to your consultant?
Yeah, so I would certainly speak to your clinical team, just because often the GPs, they have a hard job. They've got to be sort of a jack of all trades and know a bit about everything. But when it comes to eye specific stuff, they'll refer you back. They'll refer you back to your team. And, I think if it's a case of you wanted to have a second opinion, for example, yes, you could go by your GP and they could refer you to another eye unit, or you can actually speak to your clinical team and they'll also happily do that, usually for the most part, just refer you to somewhere else for a second opinion if needed. But if you do want to discuss, treatments and things, you're happy to stay with your team, and it's more about, why have I not been offered this, or what are my options? I would try and tap into nurse support there, and I'm only saying that because I know that usually that's what happens at our eye hospital. If they know I exist and I've encountered patients, that then they'll tend to get in touch with me and say, I've got questions about this. I didn't quite get to speak about this. What do you think? And what will happen is, if I can't answer it, I'll go back to my clinical team, but go back to the consultant and ask them. So if you have a specialist nurse there, I would encourage, try and speak to them. That is what they're there for. They're also there to help with the support and emotional support or practical support. Otherwise, the eye clinic liaison officers, not every hospital will have one, but again, they're really, really useful. And if all else fails, usually your secretarial team, they will field all of your queries. So it might take a little bit of time. You might not get an answer straight away, but if you do contact your consultant secretary, they can at least pass that information on to the team. I would certainly encourage you to ask the questions. And I know it can seem scary, and I know everyone seems really busy, and they are, and we're all running around, but it's worthwhile just asking them and persisting. And particularly if you've got quite big delays between appointments, you want to get the most out of the appointment while you're there if you can. And if anything's been unanswered, or something crops up in between, I encourage you to get in touch with somebody. But I'd try specialist nurses, ECLOs, and if you're really not getting anywhere, your consultant secretary.
Great, thank you. I'm very aware of time. We're very nearly 8 o'clock. There are still quite a lot of questions that we haven't had a chance to answer, but we have run out of time. So unfortunately, we're not going to be able to answer all of those. Robin, whilst I'm kind of finishing off, could you just kind of skim through those and check if there are any that look really important for us? And if we haven't answered your question, please do get in touch with the Glaucoma UK helpline, and they will be happy to answer your question. And perhaps, Rachel, if there are questions that the helpline can't answer, would it be okay if we forward those to you?
Oh, 100%. I'm more than happy for anyone to contact me. It's always a bit difficult if you're not an eye hospital patient to answer very specific questions about your care, but I can talk in general terms, you know, and then hopefully that's useful, you know, even if you're not a patient of mine, just to give an overview. So, and if you are a Manchester patient, then I definitely would say contact me, because I'll at least be able to access your records and we can talk in a bit more detail. But yeah, any questions, happy to field them.
Great.
There are a couple, Liz, that are probably just a quick yay or nay. So can I fire those over?
Go on. Yeah.
So alternative treatments such as acupressure or acupuncture.
I mean, I would never say nay to anything, but I can't tell you there's absolute evidence there for it. But, you know, any complementary therapies, I think, speak to your clinical team. Not an absolute nay, but there's nothing that I can say is a concrete, yes, this will work for you.
Fab. Underactive thyroid linked with normal tension glaucoma?
So not necessarily, no. I mean, you can get issues ophthalmically when it comes to the thyroid and overactive, but I wouldn't say underactive necessarily is linked to glaucoma as such, no.
Okay. And the last very quick one, there's a couple around dry eye, but is it true that drops can cause dry eyes?
Yeah, unfortunately, a lot of the drops we give you can make the dry eye worse. So usually you might be a little predisposed to it, and then having something on that ocular surface regularly just disrupts it. So yes, quite often we'll find a lot of our patients end up with dry eye, and obviously there's loads of lubricants out there that are available to ease that for you if that is happening.
I think that's it. There's a couple around where things can be sourced, but if people want to contact the helpline, they should be able to give advice on those.
Brilliant. Thank you, Robin. So we're going to launch another poll now, again, just to ask how much you feel you know about primary open angle glaucoma, just to see how much you've learned during this session. Whilst you're doing that, thank you everyone for your questions, and thank you, Rachel, for your fantastic presentation and your great answers to the questions that we were able to put to you. We'll just give people a moment longer to do the poll. Okay, so as I said, if you've got any questions that haven't been answered or any questions that occur to you afterwards, please do contact the helpline. They're open 9:30 a.m. to 5 p.m. Monday to Friday. You can call them on 01233 648170 or email helpline@glaucoma.uk. And they will be very happy to answer any questions that you have. We've got a little break of Christmas, and then we'll be back in January. On the 11th of January, we have a session with one of our helpline advisors, Trish, who will be here to answer any questions you have about glaucoma and eye drops. So that's 11 January at 7 p.m. And then on the 15th of February, again at 7 p.m, we have Winnie Nolan from Moorfields Eye Hospital talking about primary angle closure glaucoma. So if you'd like to come along to those sessions as well, you'd be very welcome. When we finish this session, we will be launching a little feedback survey. We do really appreciate any feedback you give. I know some of you come to a lot of these sessions and keep seeing this survey and probably get sick of it, but we do really value your feedback. So if you can fill that in, please do. And that just leaves me to say again, thank you very much, Rachel. It was a really useful, informative session.
Okay.
And that's us done. So thank you everyone for attending. Until next time, goodbye.